It's exciting than what transpired in your life.
That's okay. That's enough excitement.
I'm going to try to do a little drawing, although I did scribble on some sheets here. I thought we'd talk about nasal trauma because you had a case about a month ago, and you sent me some pictures and talked on the phone about the patient. So we're going to talk about nasal trauma. I think probably a better term would be nasal facial trauma. Yes, you can isolate the nose as the site of injury, but it's so intimately associated with so many other structures that we must take that into consideration. Just some drawings that are very, very poor, but might help illustrate a couple of things. When we think of the nose, obviously, we think of this projecting structure that the good Lord gave us. But I think it's good to remember certain terms. This is always referred to anatomically as the tip of the nose. So if you're writing a note, you want to use tip. This is the root of the nose. Now this area here is best referred to as the dorsum of the nose. Now I know that some people have seen and they use the word bridge. It's not the best word to use when you're describing this part of the nose. It's not the best word. You should just refer to that as dorsum. So if there's a question of some disturbance that happened from here to here, you'd say a dorsum injury, a central or lateral dorsal injury. The other thing to always remember, I'll try to draw this structure here, this angle between the nose and the face, is just filled with blood vessels, inferiorly and superiorly, lots of them. Lots of blood vessels. This comes off the ophthalmic, this comes off the facial, which is off of the external maxillary. There's lots of blood here in this part of the body. And the skin is thin and there's not much space there. Maybe I'll try and draw a little illustration here. Don't do a very good job, but anyway, same thing. This would be the center, the dorsum of the nose. Always remember that there's lots of blood vessels. That has an influence on the factor when there has been an injury.
That's the injury, I guess.
When we think of the nose, we think of a bony part and a cartilaginous part. This is bony here. This is cartilaginous in through here. This does not give when there's an injury. So you might get a call from a mother. As a provider, you'll get a call from the mother, maybe a child fell down a concrete step with their nose. Or another common one would be someone playing basketball and jumps up and gets an elbow to the nose. Probably the most common one of all in this day and age is people that get into altercations, have their nose struck. Car accidents, not near the number that we used to see years ago because of restraints and airbags. They have made a dramatic, remarkable improvement in facial injuries in automobile accidents. They're just remarkable what they can accomplish. So remember, there's a bony part and there's a cartilaginous part. And let me, I think I can illustrate here now. When we think of the just anatomically, you would think of the nasal bones. You don't want to think of them as plates that just fit there on the nose. They don't do that. If we were to take a cross section, you'd see a nasal bone come up from each side. And these bones are not plates. I think of them as shingles on a roof. The nasal bone, as it comes up to the midline, it meets its opposite partner with a little curl that's really very tight and strong. So they unite in the middle. But above this bone, this nasal bone, this is the center, this bone is remarkably supported by this frontal bone that comes down and creates a shelf underneath that bone. It creates a shelf for support. Otherwise, it would just move away or come up or fall in. The same is true with this cheekbone or the maxilla. It comes up, it comes there, and then it forms a plate underneath the nasal bone. And sometimes part of the maxilla will come up and just freely come into the opening, form sort of a little wing of bone, wing of bone in through there. And then there's some adherence between a plate of cartilage here as well. So the nasal bones are well supported. They don't move because they're like shingles, and they fit and they lap, and in here it actually interdigitates itself. Part of this nasal bone comes above the maxilla, and the other part goes underneath it. So it's remarkably tight and strong. You can touch your own nose and feel the support that it has. Well, if it was just a plate, then it would move around, but it doesn't move around. Now, as far as nasal injuries are concerned, I think in my mind, going back years, I want to keep three things in mind, because they'll tell you something, either on the phone, or they may call you from the emergency room about one of your patients, or they may come into the clinic. The main thing is there's been some trauma. Is this trauma long-term going to result in a deformity of the nose cosmetically? That's number one. Is this trauma, and you may or may not know the extent of it, is it going to end up in a deformity, particularly in a nose that's never been injured before? Number two, is the amount of blood that's coming from the nose at the time of injury excessive, or is it just it bled a little bit and it stopped? And the other thing that some people would put ahead of the other two is, has there been an eye injury? If there's been an eye injury that's overlooked, it can be terrible, and they occur. Whenever there's trauma, the distance from the eye to the bridge of the nose is just a few millimeters. So those are the three things you have to take into consideration. Is there going to be a deformity? Is the nose bleeding unusually? And has the eye been injured? Now, when there's a trauma to the nose, a lot of this is very common to you people. As providers, you understand. The thing to remember about the nose is that whenever there's trauma, there's going to be swelling, a lot of swelling. And if I can do this properly, there's going to be a lot of swelling because of all these blood vessels. And it's usually rather rapid swelling. Someone might hit their nose and end up in the emergency room or in the clinic, and there's so much swelling, you can't tell anything. Just swelling everywhere. Now, the bleeding from the nose may have stopped, but they just have all this swelling, and if it's a day later, particularly if they went home and laid flat and invited all this swelling to really develop, you're going to have a lot of swelling. And you say, well, gosh, it's undoubtedly you hit your nose, and most blows to the nose, believe it or not, are lateral blows. People can generally see something coming, and they can turn just a few millimeters, so most, I'd say 95% of the injuries are to the lateral dorsum. This is the center dorsum. This is the lateral dorsum. They see just enough to turn, and they catch it. Very seldom do you see a direct central injury. You could. Those injuries create such force to the nose that they end up often with a skull fracture, and these people succumb, or they're in the intensive care and they're more concerned about CSF bleeding and all kinds of ramifications centrally. They're not worried about the nose very much. But most of them are lateral injuries. A lot of swelling, and they call you and they say, so-and-so got into a fight and there's a lot of swelling. What do you do? And you say, well, does it stop bleeding? Yeah, it stopped bleeding. Then usually there's just a simple tear of the mucosa in the nose, and the bleeding is never significant. I should say, the vast majority is never significant. It's just simple bleeding, and then it stops. It can be both sides. But then you have all this swelling. Now, the question comes up about x-rays, and as I was mentioning to Dr. Lloyd, to me, simple x-rays are worthless. They don't tell you anything about the nose. The only way to really get an evaluation radiographically is to do a very elaborate CT scan. Then you'll pick up deformity. A simple x-ray is very hard to read and often overread and doesn't really mean anything. But so what do you have to do? Well, you have to allow this swelling to go down. And that's the great thing about nasal injuries. As long as there's not excessive bleeding and there's not an eye injury, you have a grace period of anywhere from 5 to 10 days to do absolutely nothing. Absolutely let the swelling go down so that you can see if there is a deformity of the nose. And the best way, since you're not going to use x-rays, is just to feel the nose and see if you can feel where there might be a depressed fracture on one side, up in the bony part. The cartilage never has a problem, unless there's a tear with some kind of an instrument where they're struck on the nose and they tear into the cartilage. Well, that's an entirely different type of open injury. So there might be a depressed fracture there, but if there's all that swelling there, you wouldn't be able to see that. But remember, you have a grace period. So if they call me from the emergency room like years ago and they say this happened, check about bleeding in the eye, and we probably won't see that patient for 4 or 5 days in the office, and have them sleep on several pillows to get the swelling to go down, because there's a lot of swelling. That's why we have these characteristic so-called black and blue marks around the eye and cheek and on the nose and on the cheek. Then you'll be able to tell if indeed there's a depressed fracture by feeling it and having someone comment. Always remembering to ask the patients, have your noses ever been injured before? Because sometimes they won't tell the truth. They come in after an injury, it's previously fractured, and you don't know that. You feel that there's something wrong, but usually if you question them enough, they'll tell you if it's been injured before. So there's a depressed fracture in the dorsum here, and force always has to go somewhere. It has to go through the nose, and there's almost, in 80% of the cases, an override over here. The force goes through and pushes the nasal bones outward. So you have a depressed fracture here and the override over there. And it's obviously been injured. And once again, no problem with epistaxis or eye injuries. Then you can correct this. This is bony in nature. Remembering that these nasal bones and the associated structures from the maxilla and the frontal act as shingles. So you can literally lift them up and they'll stay in place. You might say, how do you do that? Well, it's a procedure that is painful, and whatever you do in the nose, you're going to start some bleeding again. So you don't do it in an office. I've tried that. It never works. Never, ever works. It should be done electively in an outpatient, and they should be given a general anesthetic, and they should be tubed so that blood doesn't rush down into their larynx and trachea. Just tell it's going to bleed. Tell the anesthesiologist you want this patient tubed or use an LMAS so that blood doesn't get down there. Then you use an elevator, which is nothing more than a nice instrument that's got a blunt end to it and a very nice handle. And then you can decongest the nose with some topical anesthetic so you can look in the nose. They're asleep now. And then you can elevate this without any difficulty, realizing that up here, a few millimeters above, is a cribriform plate. So technically, if you're not careful, you could shove this instrument through this plate. So once you, feeling from the outside and with the positioning of your instrument, you can elevate them and they'll stay in place. They'll stay in place almost all the time. They'll stay in place. Now, if there's a complex injury with a lot of other fractures around the orbit, such as a blowout fracture or a frontal fracture or a maxillary fracture, zygomat, then it might require some stability, but otherwise they'll stay in place. The bleeding will stop. Very seldom have to pack the nose. And even though they stay in place, I'll use a simple dressing just as a warning. Just leave my nose alone for about 2 weeks, and no sporting activities for 2 weeks. And generally they heal rather nicely. We sometimes overcorrect. We'll elevate this fracture out just a little bit more than it should be, just a slight bit, and leave this one pressed in, but maybe not as tight, because sometimes there's a slight little shift as they heal. It's very minor, but you just learn to correct for that. And then they usually do quite well. I don't use any packing or any stiff splints on the nose at all, but as far as activity is concerned, for a good couple of weeks, they should not be doing anything. Now, you might say, why do you keep mentioning blood? Well, in the eye, the eye is obvious. You can end up with blindness from a blow to the eye. We know that. We can tear the cornea, we can dislocate the lens, we can tear into the retina, we can obstruct and traumatize the optic nerve. A simple blow to the eye can cause blindness. You have to be very careful about that. The reason we're concerned about unusual epistaxis is that sometimes there's an injury in this area that transmits force. Once again, force has to go somewhere. It can go back alongside of this lamina and cut into two important ethmoid arteries. And if you do, then these will bleed significantly and then stop and start again. And these arteries are branches off of the internal carotid, so they can be devils. And sometimes you can pack them through the nose and stop them. Sometimes they won't stop bleeding. You have to make a little incision and go back and clip them. That has happened to us on numerous occasions. But those are people who have unusual amount of bleeding, significant bleeding. Then it stops and it starts again in the middle of the night after a nasal injury. You say, well, that's unusual. But that is not a common thing, but be mindful of that. They call you in the morning, say, well, he had a nasty nosebleed at the time of injury, but gee, here it is 2 in the morning and the nose is really bleeding a lot and they're not on anticoagulants. So you best be suspicious of trauma against those 2 arteries up there. Any little questions I can answer for you? I'd be glad to do that.
Way back to the very beginning, did you call that the root up there?
The root of the nose, yeah.
Which is interesting because you think of a root lower, but that's.
That's the name that I got anatomically, and it's kept that. But the word bridge is sort of a bit of a misnomer. I always use the word dorsum because it's the central dorsum, lateral dorsum of the nose. So remember these support structures. These support structures around the nose are critical because you'd say, well, gosh, you know, those are little tiny triangular plates. They don't mean anything, but they're locked in real tight, really tight. And I brought a skull just to show you how they're locked in. It's just divinely made how they're fit in tight. They fit under and then they interdigitate, so they're tight. They have to be tight, otherwise you wouldn't be able to wear glasses. Things would just fall down.
So the first phone call at the front desk, they had trauma to their nose, but they're having double vision.
Right away, the nose injury is of no significance.
They go to emergency room, right?
They've got to be evaluated. I would insist in calling one of the ophthalmologists to see them.
Mm-hmm.
Now they may not because they're so busy, tried to get into an ophthalmologist, but they should go to the emergency room because if they have double vision, you begin to wonder about an injury to the eye and a blowout fracture.
That's exactly why I'm bringing it up. So
yeah.
That's the one I had when I was you're not going to believe it, I was a surgery resident at Wright-Patterson Air Force Base. First night on call, and we had a guy that had trauma to his nose and could not move one eye. One eye was entrapped because the nerve, the muscle got stuck between those plates like Dr. Demarco was talking about. He should have gone to the ER. Of course he didn't. He came to the urgent care at our little hospital at the base, and we ultimately had to transfer him. But he also had a huge amount of edema, like you said, because he was bleeding. And the ENT was on call that night, happened to be in the hospital, and tried to get this guy an airway so he could breathe because he was so congested up here. Ended up having to send him to the Miami Valley Hospital intubated so he could breathe. Just so the guy could breathe, because they had so much stuff in their nose. So I don't take nose trauma lightly, guys. It's a big deal.
Well, those 3 things that I mentioned, those are just my little victims about bleeding and eye problems. The nose itself, you know, like I say, you have this grace period, and it can be reduced when the swelling goes down. You have nothing. After 2 weeks, it starts to mend. 2.5, 3 weeks, it's tough. You can still re-break it but you don't want to let it stay deformed. You see them 6 months later. That's not very nice because that requires extensive cutting of bone to reset it, and the outcome is sometimes not favorable. Might be better, but it's not favorable.
When a person does have that much swelling, is it still recommended to do the standard ice pack over
Anything-
a couple of days to help?
Right, but the most important thing is to stay upright. Don't go home and lay in bed. If you can sleep with several pillows, stay
Well, that
upright.
makes sense, cause you don't want it to, yeah.
You can use something cold for the first 24 hours, but it's really a question of position changes that take place.
So you have a skull? You said you brought a skull?
Yeah, I brought a skull. Cool. I got tired of looking at my neighbor, so I got his skull.
I think that just means, don't annoy Dr. Demarco.
But it's been one I've had for a number of years, but you can appreciate whoever wants to look at it, pass it around. Just don't put a cigarette in its mouth. I had a resident that did that once. He lit it too.
What's his name?
Gil Senescourt.
What's the skull's name? Is that his name? Gil?
You see the nasal bones here, but see how this bone comes underneath it and supports it, and this front bone is the same way.
So this is the little
Tracy,
Yeah,
get
those are the two.
cribiform plate right here? Is
Well,
that
it's
it?
further back. If we take
Okay.
we take the cap off, you'll be able to see the cribriform plate. It's very close. There's a plate right there.
Okay.
So you can see in relationship to that, if you placed a probe up there, you could very easily tear into this plate.
So why does it seem like, I mean, I would think the dorsum of the nose would, like the bone part, extend further than this? Like,
Oh yeah,
is this all?
clear down. Remember we talked about the tip down here?
Right.
That whole thing is the dorsum.
But that's
This-
bone, right?
No, that's cartilage. the
Oh, so
lower
that's
part.
all cartilage.
That's why we move our nose very easily. This
It feels
entire
like it's
dorsum is bony dorsum, cartilaginous dorsum.
the X-ray picture.
But it
Mhm.
does demonstrate the nature of how bones become. See, and even this maximum bone comes up to form some of the opening. Now that can be broken into as well. In general, you won't have the deformity. Once you get up here and you cave that in with force, and once again force goes through, it's got to come out this side. That's why there's an override.
So do they still do it the same way with that, use that instrument? Would it be done the same way today as it was done 30 years ago?
Well, 30 years ago, we tried to do things under local anesthesia, and we never got it done right. You'd anesthetize the nose with cocaine, you'd get one pass at it, and they wouldn't ever let you get, the patient would be so
Oh,
uncomfortable,
yeah.
because you have to use a significant amount of force.
Yes.
They won't let you do it again, particularly if it's a teenager.
I think my brother might have come to you probably back then.
I didn't do it in the office.
Yeah, I don't know. I'm gonna have to ask my dad because I know.
Do it in the office.
Yeah, and it was a deviated kind of, well, whatever, broken
So
kind of
was
nose.
it a recent break? I mean,
I think so. I don't know. I'd have to, but I know he's always thought his nose was a little off, But so it might have been that he
It was
waited.
never treated, you see.
Yeah.
Could have been an injury. Didn't have any brains, did he?
I didn't want to drop your neighbor's skull, Your brother's,